Good morning. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Today I wanted to discuss with you diabetes mellitus with pregnancy. So, we want to discuss the definition, the incidence, risk factors, effect of pregnancy on diabetes, and the effect of diabetes on pregnancy, classification of diabetes mellitus, how to do screening for diabetes, what is the treatment of diabetes with pregnancy, and how to do care for newborn, and lastly some recommendation. As regards diabetes mellitus, it is a chronic metabolic disorder characterized by a relative or absolute lack of circulating insulin, resulting in hyperglycemia, glycosuria, increased protein and fat metabolism, and the tendency in some patients to ketoacidosis. Gestational diabetes is an abnormal glucose tolerance with onset or first recognition during pregnancy that is not clearly overt diabetes. And gestational diabetes classified into A1 and A2. What about the incidence? In the United States, about 1 to 2% of pregnant women have type 1 or type 2 diabetes, and about 6 to 9% of pregnant women develop gestational diabetes. Women of childbearing age are at increased risk of diabetes during pregnancy. It is something increasing during recent years. What are the risk factors for overt diabetes mellitus and gestational diabetes mellitus? Gestational diabetes in a previous pregnancy is one of the risk factors. What others? Non-impaired glucose metabolism, what's called pre-diabetes. If the body mass index more than 30 kilogram per square meter at the first antenatal visit. Ethnicity: Hispanic, African American, Native American, South or East Asian, Pacific Islander are at risk of diabetes. Diabetes in first degree relatives. Macrosomia in previous pregnancy, 4.1 kilogram. Previous unexplained perinatal loss or birth of malformed infant. Personal history of metabolic syndromes, polycystic ovarian syndrome, hypertension, current use of glucocorticoids, glycosuria at the first prenatal visit. All these are risk factors. What is the effect of pregnancy on diabetes? First, we should know that pregnancy is diabetogenic. So, it enhances the occurrence of diabetes due to insulin antagonism, due to the action of human placental lactogen, estrogen, and progesterone hormone. Also due to placental insulinase, which accelerate degradation of insulin. Second, control of diabetes is more difficult, increasing the incidence of hypoglycemia and ketoacidosis. Third, more insulin is needed during pregnancy. Fourth, insulin requirements decrease after delivery with disappearance of placental hormones. Fifth, progression of retinopathy and nephropathy. Many complications of diabetes increase under the effect of pregnancy. What is the effect of diabetes on pregnancy? Effect on the mother, like infection, chorioamnionitis, and postpartum endometritis, polyhydramnios, excess amount of liquor, amnion, gestational hypertension, preeclampsia and eclampsia, preterm labor, postpartum hemorrhage, increased operative delivery due to enlarged size baby, subsequent development of diabetes mellitus type 2, shoulder dystocia, and birth trauma. So what about the effect of diabetes on the fetus? Abortion may be in 30% of cases, congenital anomalies about 3 to 6%, like congenital heart disease, anencephaly, microcephaly, and sacral agenesis or caudal regression syndrome. Increased perinatal mortality due to ketoacidosis, hyperglycemia, preeclamptic toxemia, congenital anomalies, and placental insufficiency. Increased perinatal morbidity like macrosomia, 4.5 kilogram or more due to fetal hyperglycemia, which stimulate hyperinsulinemia in the fetus, which leads to increased lipogenesis. Neonatal hypoglycemia, hypocalcemia, and hyperbilirubinemia, IGR, cerebral palsy, respiratory distress syndrome, and hyperviscosity syndrome. What is the classification of maternal diabetes in pregnancy? We can classify them into pre-gestational diabetes, either type 1 or type 2, insulin-dependent or non-insulin-dependent type, secondary diabetes, gestational diabetes, impaired glucose tolerance of pregnancy, undiagnosed pre-existing diabetes, undiagnosed pre-existing impaired glucose tolerance. Let us go to the Priscilla-White classification in 1949. What about this White classification? This classification was done by a researcher called Priscilla-White and include classification of diabetes into different categories. Class A, 1 and 2, which is gestational diabetes. In class A1, the fasting blood glucose is less than 105 milligram deciliter, and the 2-hour postprandial less than 120 milligram deciliter. And the therapy include diet control. No need for oral hypoglycemia or insulin. While class A2, also gestational diabetes, the fasting blood glucose is more than 105 milligram, and the 2-hour postprandial is more than 120 milligram, and the proper therapy is by insulin. Class B, according to the age of onset and duration, age of onset over 20 and duration less than 10 years. Class C, between 10 to 19 years, age of onset, and the duration between 10 to 19 years. Class D, before 10 years in the age of onset, and duration more than 20 years, also associated with benign retinopathy. Class F, any age of onset and any duration but associated with nephropathy, and proteinuria here is more than 500 milligram per 24 hour and before 20 weeks gestational age. Class R, any age of onset and duration associated with proliferative retinopathy. Class H, any age of onset and any age of duration but associated with ischemic heart disease. All these types treated by insulin. Another type called T, in which there is periorenal transplant. Class RF, retinopathy and nephropathy, and all of them should be treated by insulin. This is the researcher. This is a picture of the researcher, Priscilla White. She was born on 17th of March in 1900 at Boston, and she is pioneer in research of diabetic women during pregnancy. Screening of diabetes during pregnancy, we should do it in presence of one or more risk factors, like gestational diabetes in previous pregnancy, non-impaired glucose metabolism, pre-diabetic case, body mass index more than 30 kg, ethnicity like Hispanic, African American, Native American, diabetes in the first degree relatives, macrosomia in previous pregnancy, previous unexplained perinatal loss or malformed infant, glycosuria at first perinatal visit, and lastly, personal history of metabolic syndrome and polycystic ovarian syndrome. Screening and diagnostic testing for gestational diabetes mellitus, two-step approach. First, screening 1 hour, give the patient 50 gram glucose and measure the plasma glucose level. If more than or equal to 130 milligram per deciliter, it is abnormal. Another test, diagnostic 3-hour fasting glucose tolerance test. Give the patient 100 gram glucose after measuring the fasting plasma glucose level, then measure the plasma glucose after 1 hour, 2 hour, and 3 hour. So what is normal values? Normal fasting glucose below 95 milligram deciliter. Normal 1 hour glucose less than 180 milligram deciliter. Normal 2 hour glucose less than 155. Normal 3 hour glucose less than 140 milligram deciliter. If we found abnormal 2 or more glucose values, this suggesting gestational diabetes. One-step screening test. How can we do it? We administer a fasting 75-gram oral glucose tolerance test. Diagnose gestational diabetes mellitus if one or more thresholds are met or exceed: fasting 92 mg per deciliter, 1 hour 180 mg per deciliter, 2 hour 153 mg per deciliter. What about overt diabetes or pre-existing diabetes mellitus in pregnancy? They have glucose level of the following: hemoglobin A1C more than or equal to 6.5. Also, fasting glucose more than or equal to 126 milligram deciliter, or random plasma glucose equal to or more than 200 milligram deciliter. These levels can possibly indicate that diabetes mellitus type 2 was present prior to pregnancy. Pregnant with impaired glucose tolerance. What about that? It includes patients with hemoglobin A1C in a range of 5.7 to 6.4, known pre-pregnancy or diagnosed at the first prenatal visit. For those with PCOS on metformin treatment, metformin will increase fertility and should continue during the first trimester till 12 weeks as decreases miscarriage. If not other signs of gestational diabetes mellitus, should discontinue metformin after first trimester. What about care of patient with diabetes mellitus type 2 prior to pregnancy? Prenatal goal: hemoglobin A1C 6% to reduce the risk of adverse fetal and maternal outcomes. Prenatal counseling to advise weight reduction of at least 10 pounds. Exercise and meeting with a dietitian. Give aspirin 81 milligram at 12 weeks. Those with diabetes mellitus type 2 don't need to start aspirin prior to become pregnant. Do baseline labs like CBC, AST, ALT, creatinine, 24-hour urine protein at initial obstetric visit. Women with pre-gestational diabetes should have a baseline of ophthalmology exam in the first trimester and then be monitored every trimester as indicated by degree of retinopathy for fear of deterioration of retinopathy. Treatment of gestational diabetes include antenatal care shared between obstetrician, endocrinologist, and dietitian. Frequent visits than usual in normal cases. See the patient every 2 weeks. Frequent blood sugar test and blood pressure monitoring for the risk of preeclampsia or gestational hypertension. Instruct the patient to avoid prolonged fasting instruct the patient to avoid excessive weight gain, teach the patient signs and symptoms and the treatment of hypoglycemia, routine testing for albumin, sugar, and acetone, routine fundus examination each trimester, hospitalization for cases with poor diabetic control, ketoacidosis, pregnancy-induced hypertension, or obstetric complications like preterm labor or premature rupture of membrane. Targeting treatment based on 3-hour testing, fasting glucose in 3-hour testing. If less than 95, start diet control. If between 96 and 126, start glyburide. If more than 126, start insulin therapy. You should encourage lifestyle modifications, dietitian referral to educate regarding reduce the carbohydrate diet. Carbohydrate constitutes 33 to 40% kilocalorie per day, while protein 20% and the fat 40% per day. Exercising for 30 minutes every day in most days of the week. Do follow up in 1 to 2 weeks. Glucose monitoring following diagnosis of gestational diabetes should be 4 times daily, morning, fasting, and after 3 meals. Fasting glucose less than 95 mg deciliter. 1 hour postprandial less than 140 mg deciliter. 2 hour postprandial less than 120 mg deciliter. Oral medication and or insulin. Oral medications like metformin or glyburide or insulin with different types like short-acting or rapid-acting insulin or long-acting insulin, indicated if glucose level remain elevated despite lifestyle modification. When to start medications? If equal to or more than 50% of glucose values are elevated during a 1 week period, or if more than 2 glucose values are elevated by more than 10 mg deciliter at the same meal during a 2-week period. Oral medications and the insulin are equivalent in efficacy. It is suggested by some. So, this table compares different lines of therapy: metformin, glyburide, insulin. As regard oral hypoglycemic drugs, metformin and the glyburide should only use one oral medication. Don't use both together. If not controlled on one, need to initiate insulin. It is not yet approved by FDA. It is considered pregnancy category B, so it is safe. It crosses the placenta, but not associated with birth defect or short-term adverse neonatal outcomes. Long-term metabolic effect on children with in utero exposure are limited. We start metformin by 500 milligram daily with food. Follow up in 1 to 2 weeks. Maximum dose 2000 milligram daily, divided 2 times per day. While in glyburate, we give a dose 2.5 milligram daily, 1 hour before meal, and do follow up 1 to 2 weeks. Maximum dose is 15 gram daily, and the dose should be divided twice. Shouldn't be used in patients with sulfur allergy. And one of its advantage, lower failure rate comparing to metformin. What about the insulin? Can add to the regimen for pregnant who have uncontrolled gestational diabetes. Despite lifestyle modification and the oral medication, or elect, don't use the oral medication. Of course, should be prescribed by senior obstetrician and with the help of endocrinologist. Insulin doesn't cross the placenta. Different types of insulin, rapid, intermediate, long-acting insulin can be used. Total dose range between 0.7 to 1 unit per kilogram per day. Half total dose given is rapid acting insulin like Humalog and Novolog in 3 divided doses at meal time, and do follow up in 1 to 2 weeks. While the remaining half of the dose is long acting insulin like Lantus. This table shows some types of insulin available in the market. As we said, it is better to give half of the dose of insulin rapid acting like Aspar, Novolog, or Lespro, Humalog. The onset of action within 15 minutes, peak effect 60 minutes, duration 2 hours. Start with each meal, so 3 times daily. This is half of the dose. What about the other half? Long-acting insulin like Detimir, Levemir, or Glargine, what's called Lantus. It is long-acting insulin. Its onset starts after 2 hours, while the duration of action more than 12 hours. It is given 1 dose every 24 hours. Other types of insulin here, regular insulin, intermediate acting, and the NPH, intermediate acting insulin. Here is an example or suggestion of certain dose for insulin in cases with gestational diabetes mellitus. Start in the first trimester with dose 0.7 unit per kilogram, while from 14 to 26 weeks gestational age, increase dose to 0.8 unit per kilogram, while Between 27 to 37 weeks, increase dose to 0.9 unit per kilogram. At 38 weeks till delivery, increase dose to 1 unit per kilogram. While postpartum, you should reduce the dose more than 50% so you reach 0.5 unit or 0.2 unit per kilogram. And even you may stop insulin in mild cases. While in type 1 or type 2 diabetes mellitus with pregnancy, you should continue treatment as before pregnancy because the patient already diagnosed diabetes before pregnancy. While in gestational diabetes, the patient mostly recover after delivery and the blood glucose usually return to normal. So there is no need for more treatment with insulin in many of cases. This picture show you an example of rapid acting insulin like Novolog and long acting insulin like Lantus, and here the oral hypoglycemics or insulin sensitizer metformin or glucophage and the glyburide 2.5 milligram and here glucophage 500 milligram. Fetal surveillance in pregnancy with gestational diabetes mellitus. Diet control. Class A1 managed as regular pregnancy. Early induction of labor is not necessary. Can deliver at 40 weeks gestational age. Gestational diabetes mellitus on oral medications or and the insulin therapy, bi-weekly non-stress test or weekly biophysical profile beginning at 32 weeks gestational age. Monthly ultrasound to monitor fetal growth starting at 28 weeks. Detection of diabetic imperiopathy or anomalies with gestational diabetes or type 1 or type 2 diabetes mellitus with pregnancy. Measure hemoglobin A1C level. If more than 8.5%, this is associated with 20 to 25% congenital malformation. You should take care about that. Yearly transvaginal sonography for high-risk cases to exclude CNS anomalies. Do maternal serum alpha-fetoprotein at 14 to 16 weeks in high-risk cases. Do high resolution 4D ultrasound at 20 weeks to exclude congenital anomalies. Echocardiography at 24 weeks to exclude congenital heart anomalies. Timing of delivery. As regard gestational diabetes class A can deliver at 40 weeks, while women with gestational diabetes class A2 who are using oral medication or insulin, induction of labor at or less than 39 weeks if glycemic control remains poor despite oral medication or insulin use, or if additional Another indication for early delivery. For any other indications, obstetric indication. Induction of labor at 39 weeks decreases the risk of macrosomia, shoulder dystocia, and stillbirth. Route of delivery. Plan for vaginal birth if expected fetal weight is less than 4.5 kilogram and the pelvis is capacious and no other contraindication for vaginal delivery. Do cesarean section to pregnant women with diabetes mellitus with pregnancy if there is macrosomic baby and the expected fetal weight equal to or more than 4.5 kilogram or any other obstetric indications. It is recommended that women with type 1 or type 2 diabetes and no other complication should give birth at 38 weeks plus 6 days either by being induced or planned cesarean. If there is any complication that carry a risk to baby or mother, earlier delivery is indicated. Example, in cases with chronic renal impairment or preeclamptic toxemia. Intrapartum management include maintaining euglycemia during labor and delivery to minimize risk of neonatal hypoglycemia and acidosis. Glucose level should be monitored every 1 to 2 hours during active labor and 5% dextrose or insulin infused as needed to maintain glucose level between 70 and 110 milligram per deciliter. Use only one half of their usual dose of long-acting insulin the day of delivery. What about the postpartum management? Usually there is no need to continue oral medications or insulin after delivery, but in case there is need to give insulin, the dose should be reduced at least 50%. Get fasting glucose period to discharge over diabetes mellitus screening at 6 to 12 weeks postpartum. Repeat overt diabetes mellitus screening every 3 years because the patient is at high risk to develop diabetes. Breastfeeding is encouraged. Antibiotic to control infection. Care for postpartum hemorrhage is important because the patient is liable for that, especially if there is polyhydramnios and macrosomic baby due to over-distended uterus. Counseling for family planning. Care of the newborn include warming, clinical examination to exclude congenital anomalies, glucose monitoring. Try to avoid hypoglycemia because it is risky for the fetus. Oxygen and the guard against respiratory distress syndrome. Ensure patent airway. Usually need incubation for 2 days. Gut feeding plus antibiotic if needed to avoid infection. Counseling for family planning. Gestation only pills may be the ideal as it has a minimal effect on carbohydrate metabolism. IUD relatively contraindicated due to risk of infection. Conventional and barrier methods of contraception can be used because they are safe. Tubal ligation if the patient above 40 and completed her family may be a best choice. Some recommendations and the evidence rating. Screening for gestational diabetes mellitus should occur after 24 weeks of gestation in all women without known diabetes mellitus. Grade B recommendation. Initial management of gestational diabetes mellitus involves dietary changes, increased physical exercise, and blood glucose self-monitoring. Grade C. Target glucose values in women with gestational diabetes equal to or less than 95 mg per deciliter, with fasting less than 140 mg per deciliter 1 hour postprandial, or less than or equal to 120 mg per deciliter 2-hour postprandial. Grade C recommendation. Pharmacologic therapy with metformin, glyburide, or insulin is appropriate for women with gestational diabetes whose glucose values are above goal despite lifestyle modification. Grade C recommendation. Women with gestational diabetes should be screened at 6 to 12 weeks postpartum and every 3 years thereafter for abnormal glucose metabolism. Grade C recommendation. Also, fundus examination in the first trimester and repeated in the second and third trimester is something very important because of risk of diabetic retinopathy, and this is grade A recommendation. This is the last slide. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.